first event. First, I'd like to thank and congratulate Dr. Sammy Ho for being this year's president. Let's give him a round of applause. We'd also like to thank all of our supporters tonight, which is Boston Scientific, AbbVie, and Merit Medical. Without you guys, we really couldn't have any of this tonight, so thank you guys again for coming and making it out and always supporting NYSGE in all of our events. So thank you again. And thanks to all of you for showing up and coming to this wonderful night to learn and ask questions. I know it's tough. It's middle of the week, and there's a winter storm warning or whatever tonight. So, but thank you for coming. We'll try to keep it on time and short and sweet. So first, it's a real honor for me to present to introduce Dr. Patrick Okolo, who is the Chief of GI at Lenox Hill and is a Professor of Medicine at Zucker School of Medicine. And just a small thing, I mean, one of my mentors, Jonathan Biscalio, always used to talk about Dr. Okolo and how great he was. So it's truly, truly an honor to introduce you and have you talk here tonight. Thank you.
Thank you very much,
Thanks.
Dimitri. Thank you. Thank you. I was just saying that to,
No, just step back.
Step back.
Yeah.
Got it. Got it. I was just saying to Dimeo just a minute ago that I came up here to see the rich relatives, so thank you very much for having me. Just come up with just three train stops down. I know the hour is late, and I think one of the greatest gifts about developing vintage is that you learn not to be loquacious. So I'll cut to the chase. I'll share some things that I think you should think about the topic of pancreatitis of unclear origin or unclear etiology, and spare me for not making it a didactic talk, but I'm certainly willing to engage in any fine points that you might want to engage in as much as time will allow. So let me go ahead with it, and we'll convert to the laptop there. And we were just saying just before I started, you saw before I corrected the typo on it, how many people noticed that there was a typo on that? You did. But there is such a thing called idiopathic pancreatitis, but that's a topic for another day. So very good. I don't have any disclosures, and I think acute pancreatitis is another typo, basically. It is usually with no discernible etiology after you've taken a history, basically done a physical examination and lab tests. This used to be the old classification and the old definition. Obviously, with time and changes in the way that we are... Got it. And with the way that we've been able to change many of our modalities and stuff, we clearly have narrowed the spectrum of what is idiopathic pancreatitis. If you look at the epidemiology, and I won't bother you with that, but it's an equal opportunity problem. The footprint in terms of the health burden is small, but these patients consume a lot of resources because the problem and what we think about is how to think about them, how to make the diagnosis, and how to prognosticate. This is an algorithm about how we think about most of these patients. I think for the most part, 40 to 50% of patients, we can easily make a diagnosis on simple ultrasound as to etiology because most of them have biliary etiology. The others who support the Milwaukee economy or the Brooklyn economy in terms of IPAs and things like that, I think we're quite able to tell what the etiology is very quickly. But for those patients who don't have an obvious cause, we have to rely on further imaging, further discernment, perhaps genetic testing when appropriate, etc. So let me just take a few of those scenarios and see if we can talk about them, talk about the different things that we should do. So for most people who are proponents of endoscopic ultrasound, most people like Chris and of course President Sammy Ho will pick up an ultrasound scope because that ultrasound scope is very powerful in terms of what should the initial or prime imaging modality be? Most of us may have access to MRCP if it's not a weekend. And the question is, which should be primary? If this was the board exam, they'd ask you what would be the primary test. And the truth of the matter is, when you look at all of the literature that's been published in this regard and try to get a sense of which is superior, it's a bit of a mixed bag. Sammy believes EUS is superior, and he is, for the most part, quite right in terms of diagnostic accuracy. So it's right. It's got about a 64% pooled accuracy rate in terms of its ability to make a diagnosis, especially when that diagnosis has to do with a bile duct and or sometimes structural disorders. But when it comes to those structural disorders, PDVism, APBDU, and a number of things which I'll discuss, perhaps secretin-stimulated MRCP may be slightly superior to EUS in that regard. I think it's just slightly more egalitarian in that if there's a wide swath of people, it will be better in most people's hands than EUS would be as far as structural problems are concerned. With secretin-stimulated MRCP, you also get some functional idea or some functional information that you may not get with the EUS. So when you look at a recent meta-analysis that was published in GIE last year, and you step back from it and you want to get a sense of what is the best test in terms of imaging in a patient who has pancreatitis that you can't tell what the origin is, it's best to look at these two as complementary. If you're here at Sinai, or if you're at Einstein or down at our shop, yes, certainly EUS has a big role to play. But consider secretin-stimulated MRCP or secretin-associated MRCP to discern if there are structural abnormalities that may be contributing to the pancreatitis. So that's just basically what I said. Think of them as complementary rather than competitive, and you'll get a sense you'll get a better sense of what the source and the cause of pancreatitis might be. So what are the kinds of things that you might see? So pancreatism, interesting. It's one of those things that we all remember from med school. You sort of, it almost always is something that just won't go away. And pancreatism has gone through an evolution from 25 years ago when I became a gastroenterologist to now. I think we know that it is the most common congenital anomaly that there is in a population that has largely Western European genes. If you look at an Asian population and look at the studies from Japan, it's probably 1 to 2%, and not quite the 7 to 10% that it is here in the United States. The question is if it's really 7 to 10%, depending on the population. Yes.
Oh, I was scratching my head.
Were you? Yeah. I could have been convinced you wanted to challenge me on that. So, no. Good show. So sorry. Anyway, that's one of the advantages of not having any hair. But anyway, so the question is, if it's that common, how comes most patients, the vast majority of patients, don't have pancreatitis? At the time I was a fellow in Baltimore, the idea was that you had to have a double in theory. So you had to have pancreas lesion, but some other factor that was causing intraductal hypertension. And the thought was that if there's some fibrosis, definitely there is no sphincter at the level of the minor patella. So even though we may say minor patella sphincterotomy, just know that that isn't quite right. There is no muscle there. But if there's fibrosis or some impediment to the flow of pancreatic juice, then you get a situation of intraductal hypertension, and hence some people may have pancreatitis. This was the prevailing theory, and the theory for several years. It was certainly the theory for several years. And I think that theory held for many years until from Indiana, the first publication in 2007 by Chowdhury and others, looking at the exposure of patients with PDVism to CFTR abnormalities. And it appears that among patients who have no or a lower prevalence of CFTR abnormalities, they are no different from the rest of the population. And for those patients who have a higher exposure to CFTR mutations, they have a higher incidence of pancreatitis. And so I think this doesn't deviate too much from the old theory in that there has to be some impediment to flow, and you can look at that impediment to flow as either structural or an old word due to changes in the rheology of the pancreatic juice. So if the physical or the kinetic or physiochemical properties of juice changes and there is some impediment to flow, then you get this whole situation of impeded flow, intrapancreatic, intraductal hypertension, etc. The kinds of things that you see in PDVism, there are some variations it's important to know. Some people have largely advocated for us to call it dominant dorsal duct syndrome, meaning that most of the drainage comes through the dorsal ducts. There are patients with an arthritic combination. There are patients with ansa pancreatica and things like that. These are of interest to those of you who will end up in their lives taking care of many patients with pancreatic. But this is the sort of thing that we typically see. You sort of see this, and you see this dominant dorsal duct. You see it cross the plane, and it crosses the plane, it crosses the bile duct rather than arrives at the major patella with the rest of the pancreas. You often have to look, for those, for the residents in the room, it's always good just to go to these Hayes sequences and look at these Hayes sequences and get to it, as opposed to combing through the entire MRCP, and it often enrich your conversation with the radiologist. So I think we've largely discussed most of this. There is also data since the Chowdhury publication that other genetic mutations which have been associated with pancreatitis may also aggregate in the same fashion as CFTR. So perhaps this and other factors is really the reason why someone will have PDVism plus this and then have idiopathic pancreatitis. How do we treat it? I think all of you are fairly familiar with it. Basically find the minor patella. It can be interesting to find. You often find it about 2 to 2.5 centimeters proximal to the major patella. There are times when it's difficult to find, and you may have to stain it with methylene blue, give the patient secretin, in the standard fashion, and that will often help you find it. You find it, you can tell the difference on a PDVism case between North American and non-North American endoscopists. We tend to do it in the long position. The non-North American endoscopists tend to do it in the short position, and so on. Just find it, be patient, get into it, and cut the sphincter, and don't forget to stent. I think ERCP is very helpful for treating these patients, and this is why it's important to make this diagnosis. RAP stands for recurrent acute pancreatitis. It appears that clearly there's a discriminant outcome between those patients who have structural abnormalities and those who don't have structural abnormalities. Clearly patients do very well. If you look at some of the earlier studies, there's a somewhat between 80 to 100% response in terms of the absence of recurrent attacks of pancreatitis. I think this overly enthusiastic data has come into some question recently. Perhaps we have not really followed patients long, but for those patients who have no evidence of structural abnormalities, I think clearly minor pathology is the way to go. I think for those patients with structural abnormalities, the expectation is that we will only be able to help somewhere between 40 to 50% of those patients. And I think that this isn't surprising at all. What about other structural things that we find? APBDU stands for abnormal pancreatic biliary duct union. I think this is more common in a tertiary practice than many people pay attention to. I've had a patient with this yesterday, and he was a 70-year-old chap from Dublin. So I think that this is certainly more common than the east-west divide that we have. So when you look at the Japanese literature, it's a very important cause of childhood pancreatitis. Not such an important cause here, but I think we don't pay the attention to it that we should. So when you look at the weird-looking MRCP, and those abnormalities of union between the bile duct and the pancreas could be etiologically quite important, particularly if there's sphincter hypertension. Basically, what this group of disorders are those group of disorders where the pancreas and the bile duct come together outside the duodenum rather than within the duodenum. So usually they'll come together within the ampulla, which is in the intramural part of both ducts. In this disorder, it can happen anywhere outside the duodenum. It's often, most ERCPs will recognize it as having a long common channel. And then the origin, it almost seems like the PD is coming off the bile duct. This is important because you can imagine that if there's normal kinetics on a day-to-day basis, when there is sphincter of OD spasm, the flow will no longer be laminar. There is backflow to and reflux into the pancreatic duct. And under the right circumstances, intraductal hypertension and the cascade that we know clinically as pancreatitis. So find these patients. Biliary sphincterotomy is very helpful. We often see this in association with other biliary disorders, so please look for a choledococele, and particularly that's a patient to have a very good cholangiogram to make sure there are no intrahepatic associations with that, because that has downstream implications other than pancreatitis. Those are the patients who ought to be resected to prevent biliary cancers down the road. Same goes for this group of patients in terms of having a low threshold to sending them for cholecystectomy, as they are also at increased risk for gallbladder cancer. So, this is what they often look like. Long common channel, may have cystic or fusiform dilatations of the bile duct, or remember that this can occur all by itself. So just moving on, I trained at Indiana and then went on to Baltimore, and at that time, sphincter of OD disease is really how we pay the rent in terms of the advanced programs at both institutions. I think this has come to sunset, so for people like you, you've probably not seen a sphincter of OD manometry, and I think the episode study put the final nail in how commonly we did this. But I think if you look at all the studies of idiopathic pancreatitis, that at least 1 in 10 to 13% of patients will have some discernible abnormality of sphincter function or sphincter physiology. And it doesn't really matter as you comb through the literature whether that sphincter is pathophysiology is in the on the biliary side or on the pancreatic side. They both seem to contribute equally. The problem with making this diagnosis is that you can't make this diagnosis non-invasively. It is difficult to make non-invasively. We look for different ways to make it non-invasively and to make it in a reliable way non-invasively. The diagnosis, which you make with a solid-state catheter or with the layman water perfusion catheter, has an inordinately high risk of pancreatitis to the order of at least 15%, of which there's a shift towards a more severe pancreatitis. And I think this is the problem. So yes, many patients have this diagnosis. This is the cause of their pancreatitis. But the problem is that arriving at a diagnosis that you can back and then act on is a problem. And so you have to sort of then do a standard gamble in terms of the bedside heuristics. Do you do an empiric sphincterotomy or not? And we can discuss that if you have time. So this is a large problem. In 2007, there was a very a publication in Gut that we were all very excited about. This publication suggested that if you did volumetric analysis and looked at the time pancreatic juice were to enter the duodenum and looked at the volume of that and put that into a logarithm that you could predict which patients would have sphincterovoidal dysfunction. This didn't work out. What it, however, showed was that in spite of this lack of sensitivity, that if you were to find patients with evidence of outflow obstruction on secretin-stimulated MRCP, those patients responded quite well to endoscopic therapy. So it is helpful. So in terms of, if you find it, please do act on it, but this is a bit of a head scratcher still. Which patients should get sphincterovoidal manometry in this setting? You know, from my sort of old man view, I think for those patients who have debilitating symptoms, those patients who can't function, and where the love for opiates is not the major driver of their frequency in your life, I think those are the patients who you should consider doing sphincterovoidal manometry on, where available. But I personally haven't seen such a catheter in many years. Do you still have one here at Sinai? Anybody do sphincterovoidal manometry?
When I got here, we have the best one on the market. Haven't used it in like
The solid state one?
Yeah. It's
See.
pristine. You can have it if you want.
No, we'll sell it to you.
Thanks very much indeed. Yes. But you can tell that nobody's really enthused about doing it, because when you get patients sick, you really do get them quite sick. Okay, just moving on. What about microlithiasis? You know, microlithiasis is often the garbage diagnosis of advanced endoscopy. However, it is real. It is real because it really is a wide spectrum of different things. And I think for the young advanced endoscopists in the room, the older endoscopists are not making it up. I think when you do crystal analysis, it really is a major contributor to idiopathic pancreatitis. So there are really three things in this family. So you've got microliths, which are small stones that are less than 3 millimeters. You've got crystals, and you've got biliary sludge. And the vicinity of biliary sludge is being shown to be a problem. There was an animal study that never got published in full manuscript form, but it appears that that lithogenic bile is in itself able to, at least in canine models, basically able to induce pancreatitis. So this is a large number of patients with pancreatitis and with seemingly unexplained pancreatitis. The question is what to do with them. So we've done that. We've how best to collect the pancreatic juice. Do you collect it and send for crystal analysis? I think people don't do that anymore. You simply look at it, see black engine oil bile. There are many, that is a fairly insensitive thing to do. But when you have made this diagnosis, no matter how you arrive at this, most patients do well with cholecystectomy. You know, advanced endoscopists argue the other way. Why don't I remove the embarrassment of the sphincter, and then there's no need to do a cholecystectomy? But I think what's been published and what's been shown is that you ablate most of the episodes of recurrent pancreatitis if you take them to cholecystectomy. And so one would then make the argument that for those patients who cannot get cholecystectomy due to advanced stage or for any other reasons that may be outside the purview of this talk, that you should do a sphincterotomy for those patients. So just moving on. This is the sort of thing that you may find. It's an 18-year-old kid who comes who comes to you, and in the mid-Atlantic, this might be actually more common than the real northern East Coast. Young person, calcific pancreatitis. Can you make a diagnosis from this CT scan? Can you? If you said no, I'd agree with you. So you really can't. You know, it could be anything, right? You know, but because of the age and those kinds of things, it's a bit unusual. And this kid hasn't had the chance. He doesn't know what an IPA is yet, and so he's not been drinking. He doesn't know that. And there's a family history here, so that sort of thing. This is the kind of person that makes you think about it. He's young. He doesn't have toxic exposure. The pancreas is already sort of fairly advanced in its evolution, and And these are the kinds of patients that make you think about genetic etiology. So with patients with genetic etiology, they're usually younger, it's usually unexplained, there often isn't a history of antecedent toxic exposure, and those kinds of things. So they're your typical idiopathics. But often those are family history. But remember that they can be sporadic mutations. Many of the mutations, I won't bore you with sort of their pathophysiologic basis, but I think you can look at these mutations in 3 packets. There are those patients who have various mutations along the CFTR domain, and more of these mutations have been found and looked at. The classic patients that were first described in the late 90s were those patients who did not have respiratory disease. Most of the patients with pancreatic disease tend not to have respiratory disease. And so you look at those patients, and the patients who have SPINK1 mutations are another family of those patients, as are the patients with PRSS1. For those people who are older than 45 in the room, PRSS1 is the same as the old HB gene that was found in Pittsburgh. And so these mutations can contribute by themselves to idiopathic pancreatitis. I think if you are comfortable with the pathophysiology of these, if you're comfortable with the management, if you're comfortable about talking about the implications of these, you should consider sending these off and counseling your patients. If it is a burden, and if it is difficult to navigate, to help patients navigate through the meaning of all of this, then you should probably send them to somebody else who may have the wherewithal or who has the backup to talk about these things. I think without knowing what our healthcare situation is in the country, we used to be worried about sending people off for these kinds of tests in terms of pre-existing conditions. We don't know if pre-existing conditions are still an issue in this country or not, but that's something to think about in terms of sending these tests out. What about other things? I mean, I think, the typical, sort of Upper East Sider that comes up to you with a history of atopy and a history of things along the autoimmune and allergic spectrum, I beg your pardon, who has pancreatitis, like in this patient who's in places where Dr. Stapoli likes to go on holiday. So she was in Turin skiing, had pancreatitis while she was there, ruined her holiday, came back to New York 6 months later, developed another bout of pancreatitis. And you get this sort of CAT scan after episodes. Does it really give you a diagnosis? It makes you suspect something, but you could get this sort of thing when somebody's severely ill from pancreatitis. But this was after she had recovered, and this is sort of what her pancreas looked like. I beg your pardon? Well done, well done, well done indeed. Even though I did tell him before, for all the other fellows who were jealous. I'm just kidding. Very well done indeed. Very well done indeed. Very nice pickup. And so yes, so it's the sort of thing that you see, that sausage-like thing. Remember also another clue is that groove pancreatitis. So very well done. And that just refers to sort of this sort of cystic atrophy along the C groove, extending from the head to the genital pancreas. You sort of see what it looks like on imaging, sort of this cystic sort of heterogeneity in that area. That helps along with the right setting to pick up the diagnosis. So don't forget this, and don't wait for a tumor to make you think about that sort of thing. And there are all sorts of other real carcinomas that can happen. I hope this will play. You send a patient to Dr. Ho for EUS, and while you're doing it, you really can't quite tell what's in the pancreas. It seems like there is, and with one of these talks, you'll always show something like this. You can sort of see a pancreas that looks sort of mottled and heterogeneous, and something keeps coming in and out of the picture, it almost looks fairly mobile. So
in today's day and age where you may get your arugula from God knows where, it's quite possible that you could get this sort of thing here in New York City. And this isn't much of a fascinoma for people, but it's always interesting when it happens. Because the question is, can you do this case without getting goosebumps? That's sort of the question. So you can sort of see it, that there is something in something occupying that. And then, you carry on, and you just sort of see it. It's really quite well defined. You trace it out, and it's going from the head of the pancreas all the way to the tail of the pancreas. So what would you do? Well, I think the patient's now well, so you probably go to ERCP to see what that is, or get some sort of imaging to further discern that. But because they've seen this movie before, they know to go to ERCP. So you go to ERCP. Let me see if I can forward that. I know I'm taking quite a bit of time, so please bear with me. I just can't make it go any faster, so just bear with me. Let's see if I can do that. Amy, have you seen this before? I'm sure you have. I'm sure you have when the thing comes up. But there's something in there, and that's how you go to, and then you just see it. And that's just your asker is coming out of the pancreatic duct. And I think if you stay around here, at some point you'll see it. You see it. I think Sammy presented a case like this years ago before I lived in New York, and this sort of thing happens. And what do? You do a sphincterotomy and you pull it out. That's what you do. And if you're Catholic like me, say loads of Hail Marys so as you do that. But don't forget other things. There are all sorts of guessing mates. There are a number of things to think about. There are pancreatic toxins. There are all sorts of toxic exposures that are not well defined, particularly industrial exposures. Think about metabolic disorders. I am completely surprised at the number of patients that are sent to me that turn out to have triglycerides that are often quite high. And it would have been something that people sent for. The numbers were there, but nobody ever really paid attention to that. So think about that. Think about medications. This is really annoying. Are there really medications that cause pancreatitis reliably outside of azathioprine, the old heart medications for treating HIV and other things? But yes, people are quite well entitled to idiosyncratic reactions, whether that's thiazides and a number of things. It's a very long list, but certainly this is something to think about. ACE inhibitors are another group to think about. In terms of biologic plausibility, what do they do to the acinar cells that can cause people to have pancreatitis? So think about that. Trauma, particularly those who are into karate and all sorts of other contact sports, can certainly fracture the pancreatic duct and cause recurrent pancreatitis. Children on bicycles are completely notorious for that. Think about, and this is the idiopathic pancreatitis part. So if you're in South India and you have a patient who has unexplained pancreatitis, loads of calcifications, you would think of juvenile tropical pancreatitis syndrome and those kinds of things. In New York City, however, don't forget that the incidence of pancreatic biliary tumors causing pancreatitis goes up after 50. We think often about patients who are older than 50, but don't forget neoplasia. This is one reason that really also buttresses sending these patients to EUS and/or a very good MRCP to exclude that. And then there are true idiopathics. We cannot figure out the cause of these people's pancreatitis. And for those patients, no matter what you do, it's going to run a natural course that is something that we can't affect. So to conclude, and I think I've taken up time and I thank you for your patience, idiopathic pancreatitis is a moving target. The range of unexplained pancreatitis has continued to contract from the 1950s up to now. I suspect it will continue to contract
but there will be the patients who are left out of what we can explain will be more difficult to deal with. The approach to patients with pancreatitis is still the old-fashioned thing. You've got to talk to them before you employ technology, send labs, look at the labs you send, and those kind of things. EUS and MRCP in 2019 are the mainstay of looking at these patients. They are complementary rather than competitive, and sphincter manometry is largely historic, but may still play a role in that difficult to figure out patients, and you should think about them. Genetic testing, something to know about, know lots about. If you know lots about it, then you can do the whole game, take care of your patients. If not, please send them to someone who can, and your patients will do well. I'd like to thank you very much indeed. This is Badagry Beach in Nigeria. I was just there just last week as they postponed their elections. Extremely idiopathic country. So, thank you very much indeed.
Thank you so much. Our next speaker probably does not require an introduction to anyone here, but I will do it anyways. Dr. Christopher DeMeo, who's an associate professor here at the Icahn School of Medicine at Mount Sinai, and also our fine director of therapeutic endoscopy, will discuss autoimmune pancreatitis.
Thank you so much. Always difficult to follow Patrick, partly because my accent is more Long Island, but other reasons. So, would like to thank Amy and Dimitri for inviting me. It really is an honor. I love to talk about the pancreas, so when I get an opportunity, I really do appreciate it. And I thank you guys for the great turnout. I know it's not so easy to get up here sometimes, but thank you. I hope you get a lot out of it. So in the 20-ish minutes that I have, I'm going to try to focus on practical things for you guys in terms of autoimmune pancreatitis. Just by show of hands, how many people have seen a patient with autoimmune pancreatitis? Okay, so most of you, good. So it's something to think about. You know, Patrick had a great lead into this as far as patients with unexplained pancreatitis. You always need to think about autoimmune pancreatitis. There is a little bit of an art to making this diagnosis, and so I want this to be practical and that you walk away with new tidbits that will help you, discern who may be the right person to work up for this. So with that, my objectives, I'm going to review the subtypes of autoimmune pancreatitis. There are different subtypes. We'll go over the differences. We'll go over the diagnostic approach and how endoscopy can help you in making this diagnosis. There are some pitfalls to avoid when sort of getting into the autoimmune pancreatitis world. Pitfalls being overdiagnosing or missing something else that's important. And then if we have time, we'll briefly talk on treatment. So what is autoimmune pancreatitis? So it's a form of chronic pancreatitis. It frequently presents, most commonly presents as obstructive jaundice, a pancreatic mass, or idiopathic recurrent acute pancreatitis. There are two different subtypes, and we're going to spend a lot of time going over them, type 1 and type 2. But they share in common, the most salient feature of these is that they have a very dense lymphoplasmacytic infiltrate with fibrosis. And the other hallmark of this disease is that it responds incredibly well to steroids. These patients get better, they get well very quickly once you initiate steroids. So as I mentioned, there are two subtypes of autoimmune pancreatitis. The classic one that I think most of us are familiar with is type 1, which is known as LPSP, or lymphoplasmacytic sclerosing pancreatitis. The second one, which you may not be as familiar with, I think may be more common in the Western world, is what's called IDCP, or idiopathic duct-centric pancreatitis. And these two diseases have marked differences in their epidemiology, the gender distribution, histology, serology, their association with other extrapancreatic diseases, and actually their clinical course as well. So let's focus on LPSP type 1. Again, this is the classic one that I think most of us have seen. Older patients, 7th decade, it's male predominant, And these are the patients that come in with obstructive jaundice, they have a pancreatic mass, and you think, 9 out of 10 times they have pancreas cancer, pancreas cancer, pancreas cancer. This is actually not a pancreatic disease. This is part of a systemic disease called IgG4 related disease. And there's really cool reviews in New England Journal of Medicine. And the hallmark of type 1 autoimmune pancreatitis is that most cases, I say most cases, you see 2/3 of cases, have a markedly elevated serum IgG4 level. We'll talk about what IgG4 is in a little bit. But as I said, it's part of a systemic disease, and you can find other organs involved. The most common ones are the salivary glands, the submandibular glands. You can see involvement of the bile ducts, not just the distal bile duct where that runs through the pancreas, but the intrahepatic bile ducts. It can look like PSC. You can see renal involvement with tubulointerstitial nephritis and these punched out lesions, which I'll show you pictures of, and retroperitoneal fibrosis. And again, on the other side, there's a whole long list of other things that you can see. But a lot of people that are much smarter than me have figured out that all of these things are related to IgG4 in some way. And when you biopsy these other organs that are involved, they all have this lymphoplasmacytic infiltrate. And here's just some examples. These are swollen submandibular glands. Over here you see these punched out kidney lesions with tubulointerstitial nephritis. This is a nice picture of retroperitoneal fibrosis. Again, all IgG4 related. The other subtype, the type 2, is much different. This is in a much younger population. So this is in your patients in their 20s, their 30s, maybe their 40s, and it's not male predominant. There's an equal distribution between men and women. But unlike type 1, it has very distinct features. It is not part of a systemic disease. It only involves the pancreas. About 30% of cases will be associated with IBD, typically ulcerative colitis. Not that it is related to IBD, there's just an association with it. And type 2 is most likely to present as recurrent acute pancreatitis as opposed to obstructive jaundice. These patients still can present with obstructive jaundice, but they often present with sort of this smoldering pancreatitis picture where they get admitted to a hospital, they're not super sick, they don't feel well, they go home, they never really get better, and they linger for weeks and months until you figure out what's going on. But most importantly is that their IgG4 is normal. This disease has nothing to do with IgG4, unlike type 1. And I think that's one of the points I'm going to hammer home, because people tend to focus highly on the IgG4, and what you should know is that probably half of the cases of autoimmune pancreatitis you'll come across will have normal serum IgG4s. Sorry. So there are guidelines on this. There is an international consensus criteria for both type 1 and type 2. It's very detailed. This is a more user-friendly version from Suresh Chari at Mayo Clinic called the HISORT criteria, and that stands for histology, imaging findings, serology, other organ involvement, and response to steroids. And we'll go through each of these and sort of how do you use the HISORT criteria to make a diagnosis. So first of all, the pathology. What does this look like under the microscope? So as I mentioned, this is characterized by a dense lymphoplasmacytic, sclerosing, inflammatory reaction. It is often around the ducts themselves, so much so that the ducts become very constricted, and we'll see why that's important later. There is described as storiform fibrosis, so almost like an onion skinning like you see in PSC. They describe like this whorl-like pattern of fibrosis. There's obliterative phlebitis, say that 3 times fast. There's obliterative phlebitis, so the venules and vessels are involved. And you may have IgG4 positive plasma cells. Not always, but what is considered positive is if you have more than 10 per high-powered field. And then type 2, what distinguishes type 2 from type 1 is that type 2 has this entity called the GEL, or granulocyte epithelial lesion. And this is a granulocytic infiltration of the duct itself. So all of this is in the parenchyma. The ductal inflammation surrounds the LPSP surrounds the duct, but this GEL actually infiltrates the duct, and it's pathognomonic for type 2 if it's seen. So the differences on histology between 1 and 2, again, they both have this lymphoplasmacytic infiltrate. Both of them, there's a lot of periductal inflammation. Type 1 tends to be more prominent as far as the storiform fibrosis, and the obliterative phlebitis is more seen with type 1, less seen in type 2. But again, this GEL is characteristic for type 2 and helps you distinguish one from the other. And then IgG4 staining. Again, LPSP is part of IgG4 systemic disease, so you often will have an abundancy of IgG4 positive plasma cells, much less common in the type 2 variety. How about radiologic findings? So we just saw this. There are classic radiologic findings that you should all be aware of. And this is just my call that whether you're a resident, a fellow, an attending, or whatever, you need to look at the images yourself, because not every radiologist is familiar with this entity, and you'll often look like a rock star when you pick it up yourself because you took the time to review the images yourself. So as we heard, the classic radiologic finding is this diffusely enlarged pancreas, or what's called a sausage-shaped pancreas. It's really just featureless. You don't see any of the fluffy borders. You don't see a duct. You can often see this rim-like enhancement, it's like a fluid rim around it, and that's pretty classic when you see that. Autoimmune pancreatitis does not cause a dilated pancreas duct. In fact, if you see a dilated pancreas duct, you should be thinking of something else, namely cancer, but you do not see a dilated pancreatic duct in AIP because, again, that fibrotic and that inflammatory fibrotic reaction is so dense around the ducts that it compresses it. You can actually have a hard time even seeing it on an endoscopic ultrasound. And then in Asia, they often do a lot of ERCP for this disease, and they've demonstrated that you can have multifocal pancreatic duct strictures as opposed to a single stricture. Other examples, here's diffuse enlargement without the rim, and then in some cases you can have mass-like involvement where it's just focal. So let's look at endoscopic ultrasound. So hopefully these pictures are familiar to those of you that do EUS. So here's a relatively normal appearing pancreatic head and a normal common bile duct. In AIP, you'll often see a mass-like involvement of the head and a very thickened bile duct wall. It's very impressive, and I'll show you some videos. Again, here's normal pancreas, normal pancreatic body. With autoimmune pancreatitis, the whole gland looks like cancer, and you often see this fluid rim around it. Here's just an EUS. So again, the whole pancreas here has this horrific hypoechoic appearance to it. You can see hyperechoic strands. It sort of has a chronic pancreatitis look. But unlike chronic pancreatitis, it's not atrophic. It's actually quite full. And if you've ever sort of been pushed off of the pancreas when you're trying to EUS a mass lesion, that's exactly what this feels like. It's rock hard. So what about IgG4? So IgG4 in and of itself is a non-specific immunoglobulin. It can be elevated in other conditions. About 10% of people with pancreas cancer will have an elevated IgG4. You can see that it's elevated in other conditions such as chronic pancreatitis, PBC, PSC, even Sjogren's syndrome. I think Patrick's patient had Sjogren's syndrome. But it is, when it's markedly elevated, greater than 2 times the upper limit of normal, it is pretty specific for type 1 autoimmune pancreatitis. But again, about a third of cases will not have, type 1 will not have an elevated IgG4. We really don't know why. And most cases of type 2 will not have an elevated IgG4. So again, this is sort of like if it's positive and you have other things going for it, it's helpful. If it's negative, you have not ruled out this entity in the right patient. And what is its significance? We really don't know. It's like a pregnancy test. It's positive or it's negative, but it has no correlation with disease activity. It has no correlation whether you're going to respond to therapy. The levels often remain elevated after you've started steroids and the patient has recovered, and it has no predictive value as far as whether or not these patients will relapse. So back to the HISORT criteria. This is again the Mayo system. They say patients who meet criteria for one of these groups are considered to be diagnostic for autoimmune pancreatitis. So that would be diagnostic pancreatic histology or they have the typical imaging, the sausage-shaped pancreas, and say a very elevated IgG4. Or if they don't necessarily have any of these features, or you don't have available histology, and maybe they have sort of some of the radiologic features, but not the slam dunk features, if they respond to steroids. And they are quick to note that this is the weakest diagnostic category, and you always have to think about, am I missing pancreatic cancer? And we're going to talk about that at the end. So when it comes to diagnostic histology, this is where there's a little bit of an art to this. So you can't make this diagnosis off of an FNA. You can if you're lucky, but for the most part, you won't. You really need a core biopsy. And nowadays, there's the core biopsy needle of your choice is available. All different kinds. I don't really think it matters. I think it's just there is a couple nuances to doing this. So this is one of my patients with autoimmune pancreatitis. Again, that horrific, diffusely hypoechoic finding, using a 22 gauge core biopsy needle, and we're using the slow pull technique, so having the assistant slowly and continuously remove the stylet while we're going back and forth through the specimen. And then this we don't make slides out of this. This goes right into formalin, and then we alert our pancreatic pathologist that we're sending the sample, so someone with expertise in this can review it and diagnose it. And this is what you get. You get a nice sliver of pancreas, and then off of that, the pathologist can see all of the salient features that we spoke about. We actually looked last year, one of our fellows, Zach Zader, our former advanced endoscopy fellow, presented our experience using small caliber needles for EOS-guided core biopsy in autoimmune pancreatitis. So we had 29 patients with suspected AIP who underwent 31 core biopsies. Most of these were transgastric, median passes 2. And most of these were done with a 22 gauge needle. We did some with a 25 gauge needle and some with a 19 gauge needle. We were able to make a diagnosis of AIP in 23 patients, split roughly between type 1 and type 2. And 4 of them were indeterminate based on those international criteria, but they did have lymphoplasmacytic infiltration. The other 6 patients did not have autoimmune pancreatitis. In fact, only one of them had clinical features consistent with autoimmune pancreatitis, but the other ones that we did not get, that we had diagnostic tissue, but we were able to rule out autoimmune pancreatitis. In 19 of these cases, both cytologic samples and pathologic samples were submitted, and the diagnosis of autoimmune pancreatitis was only found in 37% of those patients, whereas in the same cohort of 19 patients, when we looked at the core biopsy, 100% diagnostic rate. And this is data that's been published by other groups, so this fits exactly with what others have shown. So as far as sensitivity and specificity, cytology, pretty lousy. So again, you need to send this for a core biopsy, very high sensitivity and specificity. And as far as safety, because that's always the question people ask. So we did have 5 adverse events, 2 of which were mild acute pancreatitis, but 3 of those 5 patients, and Amy, you know one of these patients, 3 of those 5 patients ultimately did not have autoimmune pancreatitis. So my lesson here is, if you don't see that diffusely hypoechoic pancreas, if you don't see that thickened bile duct, if you don't have any other strong indication that this patient may have autoimmune pancreatitis, I'd probably err on the side of not doing a core biopsy, or do it with a 25 gauge needle and maybe just do 1 stick. Sorry. Yeah?
Was there a difference in the needle size and the diagnostic rate?
No, we didn't really sort it out, but they were mostly done with 22 gauge, and just anecdotally, I can tell you that that's what I use, but certainly 25 gauge is adequate to get the diagnosis. And again, the features here were more of the patients who didn't have AIP were the ones that had it wasn't like the 19 gauge needle gave them pancreatitis, it was more that they didn't have it to begin with. I think just sticking a healthy pancreas was what indicated. So again, just to summarize the differences between type 1 and type 2. Type 1, older men. Type 2, younger people, men and female, male-female equal distribution. Differences in the histologic pattern. Type 1 mostly will present with obstructive jaundice, whereas type 2 is more likely to present with acute pancreatitis. You're going to see more IgG4 staining on the type 1 patients, and it's more likely to see elevated IgG4 serum levels, and again, that other organ involvement. Whereas type 2, virtually no IgG4 association, but in a patient with IBD with pancreatitis, you should think about this, especially young patient. So just in the remaining time, I wanted to go through a couple case presentations again, just to sort of tease out some of the salient points that I focused on. This was a guy I saw last week, actually 10 days ago. 45-year-old man. In December, he had new onset abdominal pain radiating to his back. He was never sick enough to go to the emergency room, but he went to his primary care doctor. Lab showed an elevated lipase. They put him on a clear liquid diet, gave him some pain meds, and sort of followed up with him. They got a CAT scan a few weeks later, which was read as suggestive of pancreatitis, and he didn't have that for me to review. They appropriately did an abdominal ultrasound and did not show any gallstones. He denied any alcohol, no new medications, and appropriately had a good initial workup for idiopathic pancreatitis. He had triglycerides, serum calcium, and IgG4, and I didn't endorse a CA19-9, but they decided to check it. Fortunately, all that was normal. So he came to us, and he was kind of miserable. He wasn't sure what was going on. We did an MRCP, and the head and neck of his pancreas were pretty normal. He has a normal appearing pancreatic duct, but if you look at the body and tail, he has this large mass-like swelling, and you do not see that duct at all. So we did an endoscopic ultrasound, and again, here's normal pancreatic body, and as we go towards the tail, you see this beautiful, swollen, hypoechoic. You actually see that fluid rim around it. As you go towards the tail, you see it's actually starting to become a little atrophic, but pretty typical. Actually, I was thinking maybe this guy has cancer. So we did 22 gauge core biopsy needle, slow pull technique, did a little bit of fanning technique to try and get as much tissue as possible. And we were successful in doing a core biopsy, and you'll see that in a second. See the nice pancreatectomy specimen we had here, all this white core tissue. And then this was the pathology findings. We got this back Friday night. Lymphoplasmacytic infiltrate, store-formed fibrosis, very rare IgG4 staining cells, and he had a normal serum IgG4. So I spoke to the pathologist and I said, I think this guy has type 2 because of his age and the lack of IgG4, but he did not see those GEL, the granulocyte epithelial lesions. So we're calling him type 1, which again doesn't really change anything other than his potential for relapse. Put him on steroids, spoke to him yesterday, and he's feeling much better. And we'll talk about how we're going to follow him up. Type 2, we see a lot of IBD here, we see a lot of pancreatitis here, so I've had the opportunity to diagnose a lot of these patients. And again, I just look at sort of how they present. It's very interesting to me that they all sort of have very similar features. So this was a very young person, 19 years old, with recurrent acute pancreatitis, including serum IgG4, everything normal, core biopsy confirmed type 2 AIP. These two patients with ulcerative colitis and recurrent acute pancreatitis, also young. This one, interestingly, her pancreatitis presented as groove pancreatitis, all got better with steroids. These last two patients, and Dave, you know one of these patients, these last two patients, also young, 41 and 40, also with recurrent and idiopathic pancreatitis, but both of them had autoimmune diseases. This one had vitiligo and Hashimoto's. This one had autoimmune alopecia. Again, they had the classic EUS finding, diagnosis of a core biopsy. So just sort of wrapping up those cases, I mean, where do I think of AIP in the setting of recurrent acute pancreatitis? In my experience, these patients tend to have more of a smoldering course. I assume they're going to be more on the type 2 side because most of them have negative IgG. They're more on the younger side. Excuse me, and there is a predilection for patients with IBD or other autoimmune diseases. I think it's really important to take a good history and be a good pancreatologist as far as working these patients up for acute pancreatitis. They all need an abdominal ultrasound, especially in young patients. You need to ask about occult alcohol use. Now marijuana is being implicated as a cause of pancreatitis or other illicit drugs they may be using. Really have to take a good medication history. Who knows what some of these herbal supplements and 5-hour energy supplements or whatever can do, but you have to take a good history. Patrick hit the nail on the head. You need to do good imaging, and I think a secret in MRCP is really important, particularly for ruling out pancreas diffusum. These patients need to have triglycerides checked, calcium, and in younger patients, you can check thyroid and celiac disease because there is some association with these, mostly on the autoimmune disease side, and celiac disease can lead to elevated amylase and lactase, so it's worth checking. Again, just to be complete, you can check a serum IgG4, but again, you have to know what to do with it. And then again, family history, we heard this as well. And here, I tend to send these patients to our genetic counselors, and we order CFTR, PRSS1, SPINK, and CTRC. Again, the radiologic clues: diffuse or focal pancreatic enlargement, presence of that rim, a non-dilated pancreatic duct, and I think I talked about the EUS findings, and again, FNB if you're suspecting it. Just a couple more quick cases. This is more on the painless jaundice side. So this was a 77-year-old man who presented to an outside hospital in December 2016 with painless jaundice. His workup revealed a biliary stricture and an elevated CA19-9. So again, we're suspecting pancreatic cancer, but his whole pancreas looks like this. The body and tail of his pancreas, as well as the head. And here you see that markedly thickened bile duct wall. It's really impressive. So again, we did core biopsy. We did an ERCP, and you can see it's a PSC type picture. Actually, did spyglass, so we didn't have on-site, we sent everything for core. So we did spyglass, and we saw, an inflammatory type stricture, no obvious mass or nodule, and took spy-bite biopsies. And then his pathology came back as type 1 autoimmune pancreatitis. His serum IgG4 is actually 1200. So another interesting case is an older lady with Hodgkin's lymphoma who developed a peripheral T-cell lymphoma and was started on a clinical trial with these IMABs, rituximab and nivolumab, and then she was hospitalized for acute pancreatitis. Again, her workup was all negative. She had a PET scan and her pancreas lit up diffusely. So we saw her, and again, we thought maybe she had lymphoma of the pancreas. That was our working diagnosis. And when we went in there and did our examination, she had pretty typical features for autoimmune pancreatitis. We did core biopsies in thinking of ruling out lymphoma. Sure enough, this came back as autoimmune pancreatitis as well. IgG4 negative, both serum and IgG4 staining. So again, when you have somebody with painless jaundice, they may have pancreatic exocrine insufficiency, they may have new onset diabetes, and this all may be in the setting of a pancreas mass. And the diagnosis is going to be pancreas cancer, pancreas cancer, pancreas cancer. But sometimes you get a negative FNA, sometimes you come back and you do another FNA, sometimes you do brushings of a bile duct stricture and you're not getting any cancer. These are the patients where you have to think about autoimmune pancreatitis. So a couple quick words about that. It's always going to be pancreas cancer, unfortunately. I think those of us who do this know that, but you can be fooled. Pancreas cancer can present with pancreatic swelling and inflammation and pancreatitis. In that setting, if you were to give such a patient steroids, you may see some of that swelling resolve. 10% of cases of pancreatic cancer have an elevated serum IgG4, so again, you can't be fooled. And autoimmune pancreatitis, as well as other benign pancreatic or biliary diseases, can have an elevated CA19-9. So again, you have to sort of be vigilant about all these things. And I think, again, just hammering the point home of look at your own imaging, because the radiologist may not be as invested as you are in figuring out what's going on with your patient. There are differences in imaging with panc cancer versus AIP. In panc cancer, you're going to see a hypo-enhancing mass, whereas with autoimmune pancreatitis, you'll have delayed enhancement diffusely, but oftentimes the mass is not hypo-enhancing. You'll see it'll have the same attenuation pattern as the rest of the pancreas. And again, a big tip off, if you have a dilated pancreatic duct, no good comes from a dilated pancreatic duct, right? It's either going to be panc cancer, main duct IPMN, maybe chronic pancreatitis, but you won't see this in autoimmune pancreatitis, even if you have a focal mass. And again, these are just some of the other radiographic features. And again, I showed you examples of you can have multifocal bile duct strictures. But again, don't be fooled. I think this is one of the worst cases I've ever seen in my career. This was a 37-year-old man who, of course, had like a newborn. He had relapsing smoldering pancreatitis for 4 months. He's from Long Island. He had a really good workup, saw really good doctors, multiple EUSs, ERCPs, cholangioscopies, CAT scans, MRCPs. Everything was normal. This was his pancreas when he came to see us, and I said, this looks sausage-shaped to me, but I wasn't sure what to make of this pancreatic duct. We did an IgG4, which was normal. We did a steroid trial, and I said, if you don't get better in the next week or two, I think we should repeat in EUS. We put him on steroids, and 2 days later he called me back. He said, Doc, this is the worst I've ever felt. We brought him into the hospital, got an MRCP, and sure enough, he has this big dilated pancreatic duct, dilated side branches, and a cutoff. So we went into the EUS, and sure enough, he had a pancreas cancer. So again, unfortunately, it's more likely to be pancreas cancer than autoimmune pancreatitis. 2 slides on management. Standard management is to start these patients on prednisone, 40 milligrams a day. You want to do that for 4 weeks, and then you're going to follow them clinically. You don't need to put a stent in these people. Their jaundice resolves. If those present with exocrine insufficiency or diabetes, their diabetes will actually get better on steroids, and their LFT should normalize. Again, IgG4 typically does not normalize. If it's elevated, it's not really an indicator of ongoing disease activity. It's just, once it's positive, it just seems to be positive. I usually see these patients back within 4 weeks. I get another scan. I make sure that the mass is resolved. I make sure their labs are resolved. If they're not, again, you have to raise the question, am I missing a cancer here? And then if they do have clinical radiologic improvement, you taper them by 5 milligrams a week. And usually when they're down at 20 milligrams a day, I repeat labs and I see them back and sort of go from there. And these are just some examples. So the sausage-shaped pancreas, pancreatic or biliary dilation. Here's the rim, here's the pancreas. 4 weeks after steroids, pancreas shrinks back down to normal. This was a patient who presented with multifocal masses, so one here and one there. After steroids, gone. Mass is gone. You have to counsel your patients. Relapse is very common in type 1 disease. Up to 50 or 60% of these patients will relapse at some point in a few years after you stop their steroids. The good news is type 2 is pretty uncommon. How do you treat relapse? Well, for the most part, you reinitiate steroids. Some people talk about doing a slower taper, so I usually don't taper them by 5 milligrams every week. I go 5 milligrams every 2 weeks. And then depending on their age and their comorbidities, etc., I may keep them on 5 or 10 milligrams a day for 6 to 12 months. In patients who can't tolerate steroids or fail, really the standard of care has been rituximab, which targets B cells. And I basically engage the rheumatologist to give this, and patients usually do very well. We don't really know how long to give it for. It's sort of like having IBD. They just get maintenance infusions of it, but it works really well. Azathioprine's also been used. It's been shown to be as effective or ineffective as steroids in relapse. And then what's the natural history? So if you catch this early enough, these patients do fine. But I've definitely seen patients with late phase disease that have just gone misdiagnosed or undiagnosed for months, and they burn out their pancreas. They get atrophy. They get have to live on enzymes. Pretty uncommon to see things like calcifications, but they can develop fibrosis and duct dilation. But these are the more common entities that they'll get diabetes or exocrine insufficiency. And there's some emerging data that perhaps burnt out AIP can lead to pancreas cancer, but that's still far from reality. So in summary, and I hope I didn't go over too long, autoimmune pancreatitis, rare condition, increasingly being recognized. Hopefully this is the take home that you remember, that there are 2 types, LPSP, which is part of IgG4 disease, typically older men with obstructive jaundice. Type 2, younger cohort, not IgG4 related. Think about it in your IBD patients with pancreatitis. Again, pancreas cancer is way more common, so don't be fooled, don't miss it. Understand the differences in radiology. EUS, I think, has a key role. I mean, there's salient morphologic features. We have the ability to safely do an FND with standard, small caliber core biopsy needles, and it also is important in ruling out malignancy, whether it's adenocarcinoma, lymphoma, or some other disease. And then medical management is really focused on immunosuppression, mostly with steroids, but some immunomodulators is needed. Relapses are common in type 1. And then I'll make one shameless plug to attend our live course coming up in a few weeks here. Live cases, lots of fun discussions about all these kinds of things. So thank you very much.
Alright, our next speaker is Dr. Lionel D'Souza. Welcome back. You can never really get away. Since leaving us here at Mount Sinai, Dr. D'Souza is now an assistant professor at Stony Brook, where he's the director of staff surgery, and he'll discuss nutrition and pancreatitis.
Hi, good evening. I thank Dimitri and Amy for inviting me to speak. It's good to be back. So I'm just going to discuss nutrition in patients with acute pancreatitis. Save for one aspect of nutrition in pancreatitis, almost every other one is debatable and still debated. So I'm going to try and see if I can tease out the data that we have, which is multiple small studies with sometimes conflicting results, and sort of just answer those questions. When do we feed these patients? How do we feed them? And what do we feed them with? Just very briefly, sort of. The pancreas is always secreting. Sort of interdigestive phases, usually at night between after you have dinner and before you have breakfast in the morning, and sort of just follows your migratory motor complex of the stomach. Sort of the main event starts from your first bite at breakfast and keeps going to about 1 or 2 hours after you have dinner. And I'm not going to spend, in the interest of time, I won't spend too much time on this, but it's a very intricate, regulated system. Interestingly, from the time you start chewing your food, your pancreas can be stimulated to secrete up to 50% of its maximal secretory capacity, which is actually quite interesting when you think about it. Once food gets into the stomach, it's gastric distension that stimulates the pancreas mostly to secrete an enzyme-rich fluid. And then once the chyme and the gastric juices enter the duodenal lumen, then you get bicarbonate secretion, and then based on, again, what's in the food in terms of elemental peptides, amino acids, CCK, sort of regulation, and then a bunch of other neuronal and neurological and hormonal effects, sort of just affects the digestion. So why is nutrition important in pancreatitis? So our approach has evolved quite a bit from what was originally a complete pancreatic rest strategy to some point about a couple decades ago when it was sort of recommended quite strongly to feed someone early on, to what we've settled down now to sort of an on-demand or as-desired strategy. When you have as much inflammation in your body as you do when you have acute pancreatitis, there's a catabolic state that's sort of perpetuated by prolonged fasting. So you just negative caloric imbalance, negative caloric and nitrogen balance just keeps sort of continuing. And we now know that when there's a lack of enteral nutrition, there's dysfunction to the intestinal barrier, and this can lead to translocation of bacteria, toxins that can lead to either systemic or local infections, and then also sort of make the systemic inflammatory response more profound, leading to multi-organ failure that can sometimes be persistent and quite fatal. And then we're coming to realize also, and we'll talk very little bit about this, that what we eat can sometimes affect how our gut's immune system reacts, and also there are antioxidant effects of some certain types of nutrients. So the first question is, when do we eat? They say timing is everything. The acute pancreatitis, I'm not sure we know that yet. One of the problems sort of teasing out data about the timing of food is no one actually defines. We don't know what early means. People look at 24 hours, 48 hours, 72 hours, and beyond. There are obvious barriers to early feeding when it comes to acute pancreatitis, the obvious one being the pain, and often the fear that feeding them will exacerbate their pain, especially if done too early. With the exception of a very mild pancreatitis, Paralytic ileus is sort of a given when you have pancreatitis. I tell fellows that that's an easy way to follow your patient. When their nausea gets better, the appetite starts coming back. It's a pretty good sign that you've gotten over the hump of an acute pancreatitis. Mechanical obstruction is uncommon, but when it does occur, it's usually when there's significant inflammation around the peripancreatic duodenum, causes duodenal inflammation, can cause sort of a transient stricture, and then less commonly large fluid collections, things like that, can impinge on the stomach and also cause an outlet obstruction. And then in the most severe of cases where the pancreatitis patients are critically ill, sometimes intubated, nutrition sort of takes a backseat to the initial resuscitative efforts, which is, the right thing to do. So briefly, I mean, this is one study, meta-analysis of observational study that looked at the 24-hour question, and most of these patients that were fed through an NJ tube. But you can see, aside from that their primary composite necrosis, failure, and mortality in all patients, there's really no difference in any of the parameters when it came to whether they were fed before or after 24 hours. And if you look at the middle group there with patients with severe pancreatitis, the ones that we worry about the most, it didn't really make a difference whether you fed them the day off or the day or afterwards. It's another interesting randomized control trial. Here, what they did was that two groups of people. In one group, they fed them when they were hungry, and in the other group, they fed them when they met certain clinical criteria. So their pain was better, their ileus resolved, and they used enzyme levels less than two times the upper limit of normal. And you can see again, they did start eating faster because they got hungry before they met the clinical parameters. The length of stay was shorter. And if you look at the sort of the secondary clinical outcomes, it really didn't make a difference whether you fed them early or not. And then, it's a little busy slide, but some meta-analysis looking at the 48-hour question, 10 studies, about 1,000 patients. And if you look at the top two plots there, I mean, mortality was better, all organ failure was better. In terms of the inflammatory response, it was just maybe trending towards being better. But in addition to all of that, it showed a decreased rate of systemic infections, local infections, and the need for operative interventions. This is sort of the landmark nutrition study. This was the Dutch pancreatitis group published in the New England Journal. And what they did was a randomized controlled trial. These were all severe pancreatitis patients. And they divided them in two groups. So the control group was patients who were given feeding early through an entire tube. They were all nasojejunal tubes. And the median time to starting feeds were 23 hours from presenting to the institution. And their case group was, feeds were initiated at 72 hours. If they were hungry before that, they were allowed to eat. They were given an additional 24 hours to see if they tolerated oral feeds, and if not, then an entire tube was placed. And if you can look, there's really nothing to mark. There was really no difference in either group, whether they were fed within a day or if they were fed later. And sort of the interesting part here was, of the patients in that on-demand group, 2/3 of them went home without ever having to have the tube placed. And these were all, again, severe pancreatitis patients. So the next question is, how do we feed them? So I mean, this is probably the one aspect where there really isn't much debate. It's understandable why in the old days parenteral nutrition was so attractive. Not only the idea that bowel rest or pancreatic rest was important, but if you think about it, it allows for minimal pancreatic stimulation, which allays the fears of many physicians. Which is probably why, if you look at some of the surveys, it's actually being used more often than it should. You avoid the pesky nasal tube that can be painful, uncomfortable, and the patient is already suffering from a lot of pain. Titrating TPN formula is a lot easier. You can do it on a day-to-day basis, sometimes over a few hours. You can add nutrients as you need it. And then in a disease where you're dealing with perhaps more often functional obstruction, but occasionally mechanical obstruction, you can see how parenteral nutrition is an attractive alternative. But what we come to appreciate now are the benefits of enteral feeding patients with pancreatitis. you know, these nutrients that they take, they help stabilize and promote the integrity of the intestinal epithelial cell and the intestinal barrier. Some studies suggest that it may promote the integrity of the gut-associated lymphoid tissue, may help with the immunological benefits. I think there is good reason to believe that it will sort of hasten the recovery from a paralytic ileus when they fed enterally. And the result is you have a blunted, or potentially you could have a blunted acute phase response, which can lead to less inflammation, maybe the less intense SIRS, and maybe mitigate the development of any multi-organ failure, or if it does happen, sort of shorten the period that it happens, makes it more transient, so that's a pretty good outcome. And then again, maintaining the barrier avoids bacterial translocation and also of toxins that can prevent or minimize the risk of systemic and local infection. So, I mean, these are sort of, I won't bore you with every study that's looked into because there are a lot. But these are sort of the two big systematic reviews. This Cochrane paper from 2010 looked at 350 patients, all were fed with an NJ tube, and there was significant reduction in mortality. And when they looked at specifically at the patients who had severe pancreatitis, it was even more pronounced. I believe the relative risk there was about 0.18. Clear reduction in multi-organ failure and systemic infection, and no difference in length of stay. And the separate meta-analysis with a few overlapping studies showed the same thing: significant reduction in mortality and significant reduction in other clinical outcomes like infections, multi-organ failure, and length of stay. So, as much as that debate can be put to rest, next question really came was, when you're going to feed them enterally, do you do it by mouth or do you do it by tube? And there are a lot of questions here. So when it comes to oral intake, how worried do you have to be about pancreatic stimulation? Obviously, physiologically, it will occur. The real question, does it have any clinical consequence to the patient with pancreatitis? And then if you're going to feed them, what are you going to feed them? Is it a liquid diet, low fat, high fat, normal, soft? If you're going down the nasoenteric route, are you going to use a nasogastric tube, a nasojejunal tube? How are you going to place the tube? What is the risk of aspiration with enteral feeding in patients who may have ileus or may have significant ileus? And the truth is, in patients with acute pancreatitis, up to 50% of them may not tolerate any enteral feeding, especially in early on in their admission. So this was a randomized controlled trial with a small number of patients. These were all patients with mild pancreatitis. They were given either a clear liquid diet or a solid meal. And if you look at the feeding time, time to their first meal being 1.5 days is sort of goes with the population that they were studying. And you can see, I mean, there really was, the length of hospital stay was obviously shorter because they were eating faster, but there's really no difference in terms of recurrence of pain or nausea in these patients. Another randomized trial with 120 patients, again, a clear liquid diet versus a low-fat solid meal. Here, the mean time for the first meal was about 2 days. And again, if you look at all the relevant features in terms of post-feeding pain, length of hospital stay, readmission rate for pancreatitis, there's really no difference. This is a very interesting study from Europe. Randomized control trials of about 210 patients, 70 patients in each arm, and they were all divided into either having a low-fat, low-caloric liquid diet, either an average fat content soft diet or an average fat content solid diet. Here the time to the first meal was a little longer only because they went by clinical criteria, so when they felt better, they fed them based on objective criteria like pain and ileus, etc. But you can see, as you can see, there's really no difference in recurrence of pain in either of the diets. And all this bar graph really says is, if you didn't have pain, patients who were on a solid meal went home a lot faster than any other group. If you did have pain, honestly, it didn't make a difference what meal you were on. You stayed in the hospital the same amount of time. So the diet didn't really seem to affect anything significantly. But the truth is, you're still going to need nasal tubes in some patients, and they're all going to be your severe pancreatitis patients who are not getting better. better. And question is, traditionally these have been placed beyond the ligament of Kreitz, but these are not easy to place that way. They can be placed by radiology using fluoroscopy, but getting a wire that far down into the jejunum is not easy, so they often end up being placed endoscopically. So you're sort of considering doing an endoscopic procedure on who's often a very sick patient. There are different ways to do an endoscopy. If you need fluoroscopy, you're looking at moving the patient out of the ICU to do the procedure. And God forbid if they get dislodged, then you're starting all over again. So all these things make nasogastric feeding attractive. I mean, you can place it at the bedside, it takes a few minutes. Question of aspiration risk is always there. And then I just put this last one because I see it at where I work now is a lot of surgeons will put them, they want to put it just past the pylorus and they feel that that's better. I mean, I don't, there's no data on this, but the question remains, does placing it post-pyloric really, that, whether in the, just beyond the pylorus in the bulk or even in the proximal duodenum, does that really change pancreatic stimulation? I don't think so. If it's coming from the stomach to the duodenum or you're giving it directly to the duodenum, I don't think it makes a difference. And in terms of aspiration risk, I mean, we've seen people with outlet obstructions that throw up tons of bile. So if the fluid is in the proximal duodenum and they have an ileus, the risk of throwing up and vomiting is still the same. So my personal opinion would be that if you're worried about that, you really want to place it beyond the ligament of Kreitz. Otherwise, the nasogastric tube is just as good. These are some of the trials looking at the very question of whether gastric or jejunal placement is important. In the first study, there was no difference in mortality. They saw a trend towards higher risk of, they called it aspiration, but the study didn't really define how they actually defined or identified patients who aspirated. But otherwise, there was no difference in length of stay or in terms of their ability to tolerate the feeds. Second one, again, no difference in mortality, no difference in nutritional parameters. And the last one, which was really well done, was more of a non-inferiority study. Similar rates of pain on refeeding, the length of stay was the same. The infectious complication rate seemed a little higher in the gastric group, but it didn't meet their preset criteria for non-inferiority. Also, the way they looked at infections, they took tracheal aspirates and blood cultures, so positive tracheal aspirate may not necessarily identify aspiration. In an intubated patient, there's so many reasons to have a positive tracheal aspirate. So what do we feed them? This just a very interesting slide. It sort of looks at where sort of nutritional interventions in different phases of pancreatitis. Right here at the top, I mean, this is sort of what we talked about in sort of minimizing pancreatic stimulation by enteral nutrition or parenteral nutrition, either post in the jejunum. This is once you have inflammation, you sort of, especially in pancreatitis, without appropriate treatment, you start this cycle of inflammation leading to more necrosis, leading to more inflammation, and then it just keeps going on. And there's some studies looking at whether certain immunonutrients that have an anti-inflammatory effect or an antioxidant effect that help minimize or sort of break the cycle. And then there's a whole debate about probiotics. I guess no matter what you do, what disease, is always probiotics in question. And whether they can they help in stabilizing the barrier, they sort of help the flora, maintain a flora that's more homeostatic for the patient. So prebiotics and probiotics is, the rationale for probiotic or symbiotic therapy. Symbiotic, I didn't realize this, but it just means a combination of probiotics and prebiotics in the same formulation. The rationale is pretty obvious. I mean, it restores gut integrity. It modulates immune responses against invading pathogens and helps prevent the proliferation of any indwelling harmful bacteria. You see why it would help. There's been a large number of very small studies, however, using single strains of probiotics, and they all seem to suggest that it reduces the infectious complications in patients with acute pancreatitis. Over the Dutch group, in 2008, published the last study there, which was really well done. It was a double-blinded, placebo-controlled, randomized controlled trial of about 300 patients with severe acute pancreatitis. And they used a combination of 6 strains of probiotics, which was not there in any other studies, They actually noticed some increased mortality in the patients who received probiotics. In the paper, they sort of described everything they did to see if they could figure out why there was a difference compared to all the studies that came before them. The interesting thing was, in that study, there was a much higher rate of bowel ischemia. And on autopsy, a large number of them seemed to have died from the bowel ischemia. Something they couldn't explain, but at least they recommended, at least in the paper for now, that you should probably steer clear of probiotics until we can explain that the reason for that difference. Glutamine is, again, very interesting research-wise. Seems to improve immune cell function, contributes mostly, its biggest effect seems to come from its antioxidant effects. It supports, helps supports the maintaining the intestinal integrity, decreases bacterial location and translocation of any toxins. There's a couple meta-analyses looking at this that suggest that there's an improvement in mortality and total infectious complications. Especially in the 2015 meta-analysis, when they looked at subgroups, it seems that the effect's only there when they put the glutamine in the TPN formulation. When they added glutamine to the enteral feeds, they didn't see that same effect. It's sort of supported by this other study where they gave oral glutamine supplements to patients with acute pancreatitis and didn't seem to affect any outcomes. Other things to consider is, if you are feeding someone enterally, the question comes up whether polymeric or rather elemental feeds will minimize pancreatic stimulation, will minimize it more than a complex sort of feed. There's one meta-analysis that says there's really no difference. And then there's a whole bunch of studies and research going on using vitamins and selenium, and especially with omega-3 fatty acids, to see if they can reduce or sort of mitigate the course of acute pancreatitis to limit complications and improve recovery faster. None of these studies really are ready for prime time. There's conflicting data. They're very small studies, but they're all interesting questions. So, in conclusion, I think nutrition is a very important aspect in acute pancreatitis. It does, however, require an individualized approach. I think we've gone from the approach of bowel resting to bowel rousing. I guess our take-home point, I wish that was my statement, but that was from an editorial, and I can't remember where I read that. That was a brilliant play on words there. In patients with mild, or even, honestly, probably in the majority of patients with moderately severe, based on the Atlanta classification of pancreatitis, chances are you're going to be able to feed them orally within 48 hours, at the most within 3 days, and that really should be our goal. Feed them orally, and honestly, based on the data that I showed you, I think there's no reason to start with a clear liquid diet once they're ready to eat and their appetite's back. Just give them a low-fat, low-residue diet. In severe pancreatitis, a lot of it depends on how they're doing clinically, how sick they are, how ill they are they intubated, they're not intubated, what's their mental status like. The intent should be to start feeds eventually. I would not rush into feeding them. If you sort of predicting that your patient's not going to be able to be fed soon, then you can start thinking about putting a tube in. Nasogastric nasojejunal, if you look at all the society guidelines, whether it's the ACG, the AGA, or the IAP, they all recommend that nasogastric feeding is just as good as nasojejunal feeding. I would reserve parenteral nutrition really only for those where enteral feeding is not possible, and I think from a practical standpoint, the only reason that would be is if the ileus is so bad, or there's some kind of mechanical obstruction where they're not tolerating the feeds, or they're not meeting their caloric requirements via the enteral route. Whenever considering nutrition in these feed, you have to consider the sequelae of pancreatitis, such as how bad the ileus is there a mechanical obstruction of some sort that will alter the way you treat them. And in terms of using targeted nutritional therapy for improving outcomes, I think in terms of probiotic use, my advice would be to stay away from it, at least until there's better data to suggest that it's helpful, and at least at the very least not harmful. And in terms of all the other stuff, I mean, the data is pretty much in its infancy, so we'll just wait to hear more about that. Thank you.
Okay, so last but not least, we have Dr. Lauren Khanna, Assistant Professor of Medicine at NYU. She's the Program Director for the Advanced Therapeutic Endoscopy Fellowship, so thank you for coming.
Thanks so much, Amy and Dimitri, for inviting me to speak. I know it is quite late, so we can hopefully move quickly through things, and I don't know if we're going to have time for questions, but it doesn't seem like it. So my topic for tonight is the management of pancreatic fluid collections. I have no disclosures. I think just to start at the beginning, it's important to recognize that there are two sort of different pathways of pancreatitis, interstitial pancreatitis and a necrotizing pancreatitis. They lead to different types of pancreatic fluid collections. So interstitial edematous pancreatitis is the majority of the cases that we see. It usually resolves fairly quickly, and it involves a lot of inflammation and enhancement of the pancreas, and it does not have any necrosis. So necrotizing pancreatitis is the other flavor. It's a much smaller percentage of cases, only about 5 to 10%, and you can get necrosis of the pancreas or the peripancreatic tissue. It often is associated with more severe disease, and there's different types of necrosis. You can have solid necrosis, liquid necrosis, sterile or infected necrosis, and this is a good image of early pancreatic necrosis. And this is, the second image is like the inflammatory, the peripancreatic necrosis. So those different pathways lead to different types of pancreatic fluid collections. We're going to talk about drainage, and not all of these are drainable, so we'll start at the different definitions from the Atlantic classification. So there's acute peripancreatic fluid collection, which follows the interstitial type of pancreatitis. It does not have a defined wall, and the fluid is often contained in the peritoneum or retroperitoneum by the tissue planes. It usually is sterile, and it may resolve spontaneously. If it doesn't resolve, that eventually may evolve into a pseudocyst. But it doesn't have a wall and is not well drainable at this stage. When it becomes a pancreatic pseudocyst, it's usually in the peripancreatic tissues, and it has a well-defined wall, as you can see in these pictures. We typically say it happens about 4 weeks out from the initial pancreatitis event, but I think we've all seen that it can happen much earlier, that it obtains a nice wall. And it's often thought to arise from disruption of either the main pancreatic duct or the side branch ducts that are leaking pancreatic juice into this area. Acute nephrotic collection is the early phases of the necrotizing pancreatitis. And so it can contain variable amounts of necrotizing tissue or fluid, and involve various types of tissues. And the thing that characterizes this is there's no definable wall. Whereas walled-off necrosis has a mature collection that has an inflammatory wall around it. And again, we usually think of 4 weeks out as being the typical time point that a wall could develop. One thing that is important is that a CAT scan is not always the best way to distinguish necrosis versus liquid. And that can make it challenging for decision making. So sometimes MRI is helpful, or endoscopic ultrasound. If you're going in to drain something, you will often find out whether something is liquid or more necrotic. So in terms of pancreatic fluid collections, I think it's very important clinically to determine whether or not they should be drained or not. One of the things that pushes us most for drainage is infection, but that is often the hardest to determine clinically, because almost everyone who has bad pancreatitis has a SIRS-like response, with tachycardia, a white count, pain, and I think one of the hardest clinical determinations is deciding whether this is all SIRS in the setting of pancreatitis, or whether the fluid collection actually is infected. And gas on imaging is probably the one thing that makes it easy to determine that there is an infection if they've never been instrumented. But other than that, I feel like this is a constant discussion with infectious disease and the ICU. Do you think we should start antibiotics? Do you think we should be drained? And it's a very difficult clinical decision. If infection is not in the picture, I think symptoms are the other thing that we usually use to prompt us for drainage. Pain is often the abdomen or the back or the flanks, depending on where the collection may be. And that is an indication for drainage, as well as obstructive symptoms. So a lot of patients get gastroduodenal outlet obstruction from a collection. A lot of patients also have more vague symptoms like early satiety, they lose weight, and just more subtle nausea and vomiting that could be relieved with drainage of the collection. And some patients also get blockage of other organs like the bile ducts, in which case they may have jaundice. So I'm going to talk a little bit about sort of the old ways of doing things and how things have evolved. So the initial ways that fluid collections were drained was surgical. So surgery used to involve for pseudocysts, for this simple fluid collection, surgical cyst enterostomy, whether it's a gastrostomy or jejunostomy. Surgeons would open up the cyst and staple the collection to the bowel. And for walled-off necrosis, they would do a surgical necrosectomy. And those surgeries, especially surgical necrosectomy, have a lot of morbidity and mortality. So trying to get away from that, percutaneous drainage was also pursued. And so that's usually a drain placed by ultrasound or CAT scan guidance. And so for pseudocysts, you would barely see this these days anymore, but it's just a simple drain placement. For walled-off necrosis, there's a process of putting in a drain, irrigating, aspirating, and upsizing the drains. And then we now have endoscopic drainage, which we'll go through. But the studies have shown that sort of a step-up approach is best now. But it is different by each institution, sort of what institutional culture is. And so there are some places who still rely on surgery even today. And it's an evolving practice, but I think the studies have shown initially that step-up therapy with percutaneous drainage was better, and then the studies showing endoscopic drainage have come along. So endoscopic drainage has also evolved. So for the younger people in the room, there was endoscopic drainage before there was endoscopic ultrasound, where the pseudocyst or walled-off necrosis would form a big bulge in the stomach, and the endoscopist would puncture it like a needle knife, stick a wire in, dilate open a tract, and drain things that way. You probably have, there are still some places that happens, let's put it that way. But now we have endoscopic ultrasound, which has great benefits. The problem with that sort of drainage was you couldn't see any interposing vessels, and you could only do it if you had an endoscopic bulge. So endoscopic ultrasound has helped us a lot. So the conventional technique for endoscopic ultrasound guided fluid collection drainage is and so there are also maybe people in the room who haven't seen this because of the advent of newer technologies, but it is important to know what sort of the conventional EUS drainage is. So we puncture the fluid collection with a 19-gauge needle, insert a long wire, make a tract either by needle knife or dilating catheter, dilate it up with a catheter or balloon, and then place stents. So I'll show you an example of that. So here's on EUS, a smaller fluid collection. So here you have puncture with a 19-gauge needle. On fluoro, you can see that we're starting to coil the needle and inject contrast to fill the cavity. Here you can see that the tract is being dilated with a dilating balloon. Here on endoscopic view, you can see there's some pus coming out. Dilate it further, and then we're going to put in some pigtail stents. And so we have our final result. So this process is actually quite tedious and difficult. Our nurses these days barely know how to do this. It does require a lot of exchanges over long wires and difficult endoscopic positions. And so it does require a lot of skill by the endoscopist and the staff. And it can be fairly time consuming to do all of these exchanges. But this was the way that endoscopic drainage sort of started with EUS. And when you're doing this, you're usually inserting double pigtail plastic stents. That was the initial sort of evolution. And so initially you would place multiple stents and you would bring people back for procedures. Stent occlusion is often an issue. So the next sort of endoscopic evolution was to try to use fully covered self-expanding metal stents, biliary, like we had for the bile ducts, or esophageal stents. The idea was to form a larger conduit to get into a collection, allow faster drainage, or for necrosis to allow direct endoscopic nephrectomy. The problems with those stents were that they didn't really have any way of preventing migration, so often people would use those and put double plastic pigtails through them, and they certainly weren't designed for this drainage. That brings us to sort of our current technology, which is lumen-opposing metal stents, which now come electrocautery enhanced. And they are indicated for the purpose of draining pancreatic fluid collections. I'm sure everyone in the room is very well familiar with them. They have the double sort of dumbbell-shaped flanges that anchor on the inside of the cyst and on the outside of the cyst. And this draining collections these days is so easy because you don't have to do that painful, tedious process that we used to have to do. So here, just to walk you through drainage with the lumen-opposing metal stent, here is a large fluid collection. This is actually walled off necrosis. This is the electrocautery enhanced catheter that's entered the pseudocyst, or sorry, the necrosis. This is opening the internal flange under EUS, and then here the flange that's in the stomach is opened. I think that almost everyone has seen numerous videos of that. I'm going to go through a little bit more about choosing what to do, but just to go through the complications that can happen from drainage of fluid collections. Bleeding is perhaps the thing that we deal with the most. You can have bleeding acutely at the time of the drainage, whether when you're accessing the fluid collection, whether you hit a vessel, or usually it's from a vessel. But delayed bleeding is the thing that I think most of us fear. Pseudoaneurysms can develop, and they may not have been noticed on imaging. And then I think the biggest concern these days is bleeding from inside the collection, along the walls. And that's thought to be possibly due to the stents that are there, causing trauma, or from rapid collapse of the collection. And unfortunately, when it is bleeding from within the wall, it's very difficult to manage endoscopically, and most of those patients need assistance with IR or surgery for management. Stent migration is another issue. So with the double pigtail plastic stents, that usually they don't migrate very much if they're placed alone. As we talked about, the fully covered stents that were not sort of indicated for drainage could migrate. And even the lumen-opposing metal stents can migrate, especially as the cyst cavity collapses. Sometimes they get sort of expelled from the cavity. And it's really unknown whether putting double pigtail plastic stents within them can help reduce that risk. And when those stents migrate, it is not so fun. So we do want to try and get them out, especially now for the lumen-opposing metal stents, we have 10 millimeters, 15 millimeters, and 20 millimeters. And especially the 20 millimeters can cause intestinal obstruction. And so if you know that they've migrated, you do want to try and retrieve them as quickly as possible, whether that's by endoscopy or, unfortunately, sometimes enteroscopy. So we do try and get them out before they cause trouble. But if you can't retrieve them, sometimes they could even need surgery to be removed. Hopefully that's rare, but it does happen. Buried stents can also be a problem where the mucosa can sort of overgrow the internal flange, and then you have to find a way to get your stent out. So some people will APC the edges or sort of invert the stent from the inside out. And so that can be difficult to manage as well. Other issues are perforation, which can happen most often at the time of your initial drainage if there's a problem with your stent deployment. And then stent occlusion, as we discussed, that can happen with double pigtail plastic stents, but it can also happen with the lumen-opposing metal stents, especially in the setting of necrosis. There actually is a thought that perhaps because they drain the fluid so well, the necrosis is left behind and that comes in to clog the stent. And that's the reason that a lot of people do sometimes use the double pigtail stents within the lumen-opposing metal stent to assist in drainage and prevent the lumen-opposing metal stent from being clogged. And infection within the cavity can happen, especially if there's any evidence of occlusion. So considering that the lumen-opposing stents are used in many settings these days, just to review the incidence of the complications, bleeding really is the most common one. Anywhere up to 20% of cases can have some element of bleeding. Perforation is rare. Migration is the sort of second common most adverse effect. Buried stents are pretty rare. And there can be technical problems with deployment that are a little more challenging when you're using the electric artery enhanced lumen-opposing stents because you've created a hole. And if you're doing it without a wire through your device, you may have sort of trouble managing it. Whereas when you had sort of the traditional EUS guided drainage and you put in your 19H needle and a wire, you made a little bit of a hole, but that's similar to the same hole we make every time we do an EUS FNA, versus what we're doing when we use cautery to advance through. So we have more of a hole. But usually we can manage it, especially with over-the-scope clips or suturing. And then there are adjunctive techniques that are often used in the setting of necrosis, because no matter what stent we're going to use, that necrosis is often difficult to manage and you're going to need further assistance for debridement. Many people discontinue PPIs to allow the gastric acid to enter the necrotic cavity and try and debride the tissue on its own. There's direct endoscopic necrosectomy, where, especially with the lumen-opposing metal stents, you can put your scope either through the stent into the cavity and pull out the tissue. And then some things that are needed when those techniques are not enough, nasocystic irrigation is something that you can consider. So it's, for those who haven't seen it, it's like a pigtail inside the cyst. And then you have the catheter coming out the nose. You would keep the patient in the hospital and have them hooked up to an IV pole. Always important to label it that it is not an NG tube or an NJ tube, because you don't want nurses flushing meds or food or anything through that. And so it can cause confusions on the floor. But you know, there's not great data saying whether it does help or not. But anecdotally, when other things have failed, many people do try that. Hydrogen peroxide lavage has also been reported. Who in the room uses that routinely? Yeah. So, so what you can do is dilute the hydrogen peroxide and lavage your necrotic collection. So there are some case reports or series that have adverse events, particularly like embolic events. So different people have different feelings on whether to use it or not. I think though, when you have a particularly challenging collection and you have no other option, there's no reason not to try. And then when things are getting very challenging or you're faced with a very large necrotic collection, the next options are what has now been labeled multiple transluminal gateway technique, which is basically putting in multiple lumen-opposing metal stents so that you can traverse the collections and do debridement in multiple directions. And then dual modality treatment is the idea of having endoscopic therapy as well as percutaneous therapy. So it's particularly helpful when people have necrosis that extends down the paracolic gutters where you can't access with your scope. And so you may have debridement from percutaneous direction as well as endoscopically through the stomach. And then one other sort of technical area to address is the question of disconnected pancreatic duct syndrome. So many of these people who have had pancreatitis have pancreatic duct, which has now become disconnected and is leaking. And so people have tried to study whether transcapillary stenting is beneficial or not. And I think the results are pretty mixed. So some people will advocate that placing a PV stent through ERCP to change the pressure gradient so that you can have better transcapillary drainage of pancreatic secretions and lessen things that are going backwards into a pseudocyst or a cavity. And then also address any stricture that might be there, if there's any stricture. So some people find that to be helpful. Some people think that it actually does nothing because you can't necessarily bridge the pancreatic duct in this setting in many cases. And so they would advocate just long-term leaving double pigtail plastic stents in the collection long-term with no necessarily endpoint, but it would be an alternative management strategy. So in terms of actual data, there's been many studies about the efficacy of different stenting techniques. This is one from many people in the room who participated, talking about the efficacy of lumen-opposing metal stents in wall-up necrosis. And so as you can see, this is a study of 124 patients, and with 3-month follow-up, there's about an 85% success rate with lumen-opposing metal stents. One thing to note is that only 30% of them had resolution after placement of the stent, one session of stent placement and then follow-up for removal. And I think that's something that's very important to talk about with patients when you start this process of draining pancreatic fluid collections, that this is not a one-time procedure. This is going to be a recurrent visit that they're going to, especially if they have necrosis, they're going to come back for recurrent procedures if things do not resolve after the initial session, and that is going to happen in 60 to 70% of the cases. There were failures. There were 13 patients needed IR to assist, 3 patients needed surgery, and then there were 6 patients who had complete resolution and then recurred. And so you might theorize that some of those are in the setting of a disconnected duct. And then a lot of these patients did require concomitant therapy. So 78 of them had direct endoscopic nephrectomy, 19 had pancreatic duct stents placed. Actually, what I thought was quite high proportion was 38 of them had hydrogen peroxide utilized for debridement of their necrosis, and 22 had nasocystic irrigation. I think there's a lot of sort of local strategies. So in one place, people will tend to use the same thing, and so that probably impacts how these numbers are. In terms of adverse events, it's a mix between the different ones we discussed, but bleeding, infection, occlusion, and migration were all sort of seen. And the adverse event rate is fairly high if taken in total. It's about 19%. Stent occlusion means you'll bring the patient back and do a further session at that time, which is it may be unexpected for the patient, but sort of par for the course. But I think it is important to also let patients know that when you engage in this sort of process, that it's sort of an unknown what may happen. They may be back in your ER sooner than they anticipate. This was a study that evaluated the fully covered metal stents versus the lumen-opposing stents versus plastic stents. And so I think the interesting points are just comparing plastic stents versus lumen-opposing metal stents, because I think the biggest difference is cost. And so for plastic stents are very reasonably priced versus the lumen-opposing metal stents. So I think it's important to justify our use of those. They certainly are easier for our staff and for us to deploy at the initial time, but we should be able to justify them. And I think this study does show that the long-term success rate using the lumen-opposing metal stents is higher, and the recurrence, the recurrence is very low with all techniques where people have had resolution, but patients who have required surgery or radiologic assistance in this group were higher with just having plastic pigtail stents alone. And then this was a recent study that came out looking at lumen-opposing metal stents and plastic stents. And so this is retrospective, and they were looking at clinical success and adverse events. And I think what really showed, you can see clinical success was fairly equivalent in this group across both groups, but they really highlighted that the adverse events were much higher in the patients with lumen-opposing metal stents. And they included any sort of unplanned endoscopy as event. And so anytime you have a stent occlusion or a migration, those all count as unplanned endoscopies, which definitely happens in this group of patients, and bleeding as well. And one thing that they noted of interest was here that the patients who had double pigtails through lumen-opposing metal stents had like no episodes of bleeding and did very well. And so their question was whether or not that is something that will be beneficial. And I think that comes from the idea that sometimes lumen-opposing stents work so well in terms of the cyst wall collapsing that you have increased rates of bleeding from the stent causing ulceration, or increased risk of occlusion. And perhaps we may be better off combining therapies to reduce our risk of adverse events with the lumen-opposing metal stents. And so there actually is a sort of prospective trial to look at plastic double pigtail stents and lumen-opposing stents in a prospective fashion to assess for clinical efficacy, adverse outcomes. So I think that those results should be very interesting to see. So in conclusion, I think it's very important to determine the nature of your pancreatic fluid collection. A pseudocyst versus wall-off necrosis will have a much different trajectory. In terms of your management, it's very important to determine if any sort of fluid collection actually needs to be drained. And step-up therapy with aggressive endoscopic drainage is the standard of care these days. And if it's not the case where you work, you should educate your colleagues and work towards that goal. I think it is really important, even though lumen-opposing metal stents are so easy to use, that anyone who trains in advanced endoscopy knows how to do the sort of conventional drainage technique. That first case that I showed you of the conventional drainage was actually someone whose lumen-opposing metal stent migrated out, and the cavity was too small to facilitate another lumen-opposing metal stent, and so you have to know how to drain the smaller cavities when things do happen. And we do these techniques in other areas for abscesses and things like that, but I think it's important that everyone who trains knows those, and that your nursing staff also has some idea of what it is, so when it does occur, we know how to do it. For pseudocysts, I think it's unclear which type of stent is best in terms of cost, because simple fluid may not require a lumen-opposing metal stent, and the cost savings might be better off with double pigtails, but we don't know. So I think there's more studies that need to be done to define that. For walled-off necrosis, it looks like our outcomes are probably better when we use lumen-opposing metal stents. I think it's important, like I said, to educate your patients that multiple sessions are going to be required, and some of them may be unplanned. But I think we have a lot to learn also about how to reduce the adverse events that occur, especially with those stents. And maybe we should consider putting double plastic pigtails within them for now. Thanks.
We're after 9 o'clock, so I want to thank our sponsors and all of our speakers. I'm sure if anybody has any questions, perhaps it's best at this time to just directly ask our speakers. And thank you all very much. I think it was a great attendance tonight, and a wonderful group of talks. So have a good night.